Hi, welcome everybody. Always good to see you folks. It's we've been at this for like a couple of years now, and it's always good to share the third Thursday of every month with all of you. I have the pleasure of introducing tonight's speaker. This is Dr. Reylon Meeks. She's a nurse currently working as a consultant and pediatric subject matter expert for the American College Heart Association. Excuse me. She has worked on pediatric advanced life support, PERS, curriculums, authoring chapters and scenarios for both of those. She continues to teach in a hospital setting, providing education for physicians, residents, and nursing staff. And she served on the Pleasant Hill Fire Department for 22 years, the last 10 as chief, and is recognized as the first female fire chief in the state of Iowa. Reylon was named the American Red Cross Hero of the Heartland and Fire Division and was chosen one of the 100 great Iowa nurses. She currently sits on the County Board of Health and was appointed to the Governance Committee on Interoperability for Iowa. She holds a bachelor's and a master's degree in nursing, a master's degree in education, and has completed her doctorate dissertation titled Parent Presence in Pediatric Trauma Resuscitation. I've had the pleasure of working with her at conferences, as Mary talked about earlier, and it's a pleasure from one nurse fire chief to another to introduce Dr. Reylon Meeks.
Unfortunately, one comment, Dr. Meeks' camera is not working well this evening, so you'll probably just have a phantom background for Dr. Meeks, but continue right on.
Can you hear me okay?
Yep.
Yes.
Okay, perfect. If we could just have the first slide. Tonight, we're going to talk a little bit about pediatric assessment, and it's probably one of the scariest things that you can get into in terms of emergency medical services, mainly because you just don't see it that much. The other thing about little kids is they just do nasty things sometimes, and which is terrifying to the average person out there. So anyway, we're going to try and maybe demystify it just a little bit for you and help with a really easy way of determining how sick the child really is. Next slide, please, Steve. And as Will mentioned, I am with the American Heart Association just on a part-time basis as their pediatric subject matter expert. And we are looking at right now the pediatric advanced life support materials for the American Heart Association to have a rollout in 2025 with the newest updates on research. So that is what I kind of do part-time. Next. So when we talk about kids, and I know Steve makes fun of me all the time because he'll tell me, oh, they're just small adults. Well, they're really not. Kids have a very different anatomic and physiological system, and that it begins to develop as they grow. And what you find is that they change so dramatically in the first 5 to 6 years of life that you'll see an infant that can't do anything, and by the age of 1 year already many are walking and talking. And so anyway, their developmental needs are really specific to whatever age group that you're picking up and taking a look at. Next. A couple of things about kids and EMS. We do know that there's a lot of children that die every year. And sometimes that occurs just in spite of optimal medical care. What we know is that if we can prevent injury or illness from taking place to begin with, then our kids will be healthier and happier, and we won't have the same kind of traumatic injuries that we sometimes see or the illnesses that we see. Well, when we talk about prevention, it's some of the very simple things that we talk about. Choking hazards are a big one. If you can fit it through a toilet paper tube, it's too small for a child that's less than 2 or 3 years of age. If we also talked about vaccines a lot. H flu used to be terrible, terrible disease, and H flu meningitis in the pediatric population, but a lot of that has been curtailed now just simply because of vaccines. Most recently, I grew up without seat belts, but I don't think there's a kid today that probably thinks twice about buckling in before they get into a car or the minute they've gotten into a car. Next. So there's a lot of various responses to illness and injury in the pediatric population, and there's a lot of determining factors. First and foremost, obviously, is the child's development level. The individuals that are infants certainly don't even realize a lot of times where they're at. Previous experience makes a difference too. Sometimes if you've had a child that's had a traumatic experience in an emergency department or with emergency medical services, their seemingly terrified of just the notion of it. Kids that have shots had shots before, and it was a traumatic experience. They don't want them again. Kids have also different coping strategies and how they actually work within themselves and with others. And sometimes it's very cultural. I know that the child that is of an Asian background is very different sometimes than the child with a Hispanic background versus just an Anglo-Saxon background. And the nature of emergency makes a difference too. Sometimes we have kids that don't have very good support systems. Their parents are maybe not as supportive as what they could be, or they've had a rough time just growing up in childhood and getting into adolescence. And so sometimes they'll get into things that are probably not in the best interest of them. But nonetheless, it's, they all respond just a little bit differently. Next. So when we talk about caring for the child, we really talk about including caring for the entire family. And one of the things that I think about, it's not just the child that's injured, it's every other member of that family too. So when a child is just seemingly not very sick, it takes a toll on the entire family, and it doesn't really make any difference if they've stubbed their toe, broken a finger, or if they have some kind of major traumatic injury that's taken place. Next. So really, when we think about families, we also have to recognize that different responses can occur. There are no two families that interact in exactly the same way. So really, it falls back on us to have those really good communication skills and being prepared to take care of the entire family, not just the injured infant or child. Next. The other thing that sometimes is hard to remember is that really the parents are the experts on the child, and they usually know what works best. If they tell you that the child does better laying down, then for heaven's sakes, just lay them down. If they tell you that they're sick and yet they come in and they look perfectly well, something is different that the parents have picked up on. So you really need to listen to what it is that they have to say. If you have a good historian in a parent, then a lot of times they'll be able to tell you, and you'll be able to basically diagnose what's going on with that particular child, just because they are the experts for that kiddo. One thing that I think we forget as healthcare professionals is that we are visitors in the life of the child and the family for a short period of time. We're there to help them, but we're not there to necessarily make changes unless they're detrimental to the child in some way, shape, or form. So we're there to interact with them, to help them in the process, to communicate well with them, to explain things in a manner that they can understand in order to get the child feeling better and then on their way and back home where they belong. Next. So when we talk about the pediatric assessment, one of the things that's been recognized over the years is that some people seem to have a sixth sense about which kids were sick and which kids were not. And it was never really identified, but we knew that some professionals, healthcare professionals, seem to identify it much more readily and much easier than others did. And so really tonight, what we're going to talk about is not only the kids' developmental levels and how you have to interact with them differently, but then also a very easy way of figuring out how sick are they really. And so that's what we'll be going through. We're going to give you that sixth sense tonight on whether the child is sick or not sick. Next. So the assessment of a child with an acute illness or injury requires really specialized knowledge and a different kind of skill set. It may be use of the kind of equipment that we need to use for a pediatric patient, or it could go on to how are we going to talk to that kiddo so that you can get the information out of them that you really want. Next. So in our PEDS evaluation, really there's 4 steps that are involved when we're finding out that we have a pediatric illness or injury that we're going to go that we are going to go and take care of. First thing is really that pre-arrival preparation. There's a lot of things that go into that. Do I have the mindset for taking care of this child? Do I have the right size equipment? Do I even know what kind of equipment to use? So that's part of the pre-arrival preparation. For emergency medical services, of course, the next step is that scene size up and knowing what dangers there might be in the field that you, or even in homes that you want to be aware of. The dog that looks like he's going to be really nice to you may end up, trying to tear your leg off next thing you know. So again, scene size up is always important. And then our initial assessment of the child, and then any additional assessments that might be needed based on whatever you figure out to be the injury or illness. Next. So in that pre-arrival, we talked a little bit about the equipment necessary to care for the pediatric patient. Have I pulled out some kind of a length-based tape that will tell me what sizes of equipment to use? Do I have the knowledge to care for a pediatric patient or for an infant? They're very different from one age group to the next. And am I mentally prepared to care for a child? If I have a 2-year-old at home and I'm going to pick up a 2-year-old, I may feel very differently about that individual and that call simply because I know that there's a kiddo that at home that I can relate to. So sometimes just the mental preparation is a lot and bracing yourself for the kinds of things that you might see. Next. With that initial assessment, I really want to have a developmentally appropriate approach, and we'll go through some of those kinds of things for each age group. Visual and auditory can really give you kind of that initial general impression, or what we call the pediatric assessment triangle. We'll talk a little bit more about that. And then, of course, you can have the hands-on assessment and then making a decision as to what kind of transport does this child need. Are we talking that they need to go by ground? Do they need to go by air? Do they need a fixed wing if I'm in a more rural community and perhaps 100 to 200 miles away from the nearest hospital? Next. So when we talk about the developmentally appropriate approaches, we're looking at basically 5 different age groups. Infants are very different from toddlers or the preschooler age group. You probably heard the term fearsome fours, who get into everything because they're not afraid of anything they don't know to be. School-age children are, again, a little bit different. They can converse. A lot of them are very articulate, and they can tell you what you need to know. And then, of course, there's the adolescents who don't tell you anything because they don't think you need to know anything about them. So anyway, each one of those age groups we'll talk a little bit about. Next. So on an infant, you really want to ask the caregiver for the infant's name. That personalizes the interaction with the family. You want to observe first, Oscar take second, and palpate third, because the minute that you palpate an infant and you have cold hands on a warm kiddo, or you press too hard on a belly that doesn't feel very good, they're going to start to cry. And then the auscultation is out the door. You want to make sure that you sit at the baby's level so that you can actually observe interactions between the infant and the caregiver. You want to be able to make eye-to-eye contact with these kids. And the other thing with infants is we don't want to ever forget about capillary refill. We don't use that as much in the adult population as we do in the pediatric population. But one of the things that will give you a very quick assessment on how their circulatory status is the cap refill, and that will also give you an indication as to how sick the child might be. Cap refill, a lot of times, is people will leave the child laying flat on a stretcher, and then they'll just push the nail bed, or they'll squeeze a toe. Really, the correct way of doing that is you have to elevate the extremity above the heart, and that gives you a true sense of what the capillary refill is. So I always mention that as an indicator for the infant population and pediatrics as well, in terms of how sick that kid might be. Next. With the toddlers, you really want to approach these kids kind of slowly. About the time that they turn 9 months, they could start to have stranger anxiety. They recognize faces, and if they don't recognize your face, if you come right up on them, they're going to feel like you're a danger to them. You want to make sure that you praise them to obtain their cooperation, and use lots of play and distraction tools. And you have a lot of things readily at your fingertips that you can use, whether it be dangling a stethoscope in front of them. It could be turning on or off a pen light. There's just all different kinds of things that you can utilize for distraction for those kids. You can give them limited choices. If I say, which arm do you want to have squeezed so we can get your blood pressure, your right one or your left one, they can make those choices. But the thing that you don't ever want to do is give them a yes, no answer. Because if you say, can I take your blood pressure now, or can I squeeze your arm now? And they say no, you're kind of stuck. That's not something that's not a choice that you want to be able to give them. Because then what do? Just go ahead and do it. And that's just going to make them angry, and then they won't trust anymore. The other thing that we talk about a little bit is toe-to-head assessment. Kids are used to having people play with their toes and wiggle them. So if you start down at the bottom of their bodies and then kind of move up, they won't even realize that you've done that. Using simple and concrete terms is important, and being very clear. If you tell a 2-year-old they're going to go to a CAT scan, they want to know where the cat is or where the kitty is. If you tell them that you're going to, that they have diabetes, I had a 3-year-old tell me, he started to cry, and I said, "What's the matter?" And he said, "Well, I'm going to die from beatus," he said. So, being careful about what your terms are. They can understand more than they can tell you. But don't ever think that they aren't listening, because they are always listening and picking up things that you probably don't want them to, especially things like cuss words. Next. With this preschooler, you can use those simple terms. These kids are very big in exploring things, and they love to handle equipment. You can actually have them hold the or diaphragm of the stethoscope right on their chest, and they'll a lot of times will hold it for you, because they like to do that. You need to set limits on their behavior. What I'm going to do is I'm going to strap you on this cot, and it's going to be just like your seatbelt is in a car. So they understand some of those kinds of things. They like games or distractors. And so if you have in the back of your squad or wherever you might be, you can almost play a game of I see and then describe whatever the item is, and the kids will be watching for that. The other thing with these kiddos is they can only focus on one thing at a time. So before you do each intervention with the child that is this age, you really need to say, okay, we're going to squeeze your arm now. I'm just going to give it a real tight hug. And they'll understand that term. But if you say, well, I'm going to give you, we're going to squeeze your arm, and then we're going to listen to your chest, and then we're going to look at your eyes, they will still be back on squeezing the arm, and they won't hear the other 2 items, because that's all they can focus on. It's just the one thing at a time. Next. With school agers, you want to speak to the child first and then to the caregiver. These kids will interact with you. It's no different. They're used to being in school, and they will answer teachers' questions. You need to anticipate the child's fears. If they were doing something they weren't supposed to be doing when they got hurt, it's very likely they might not tell you anything that's gone on. And so you really have to sometimes dig it out of them a little bit and say, are you scared of something? They'll say, yeah, I'm afraid that mom or dad are going to be
5 more
mad
minutes, babies.
because I did something that they weren't supposed to do. So again, those are the kinds of things that take place. You want to explain procedures pretty readily to them and provide them with privacy. They've been taught that they don't run around without clothes on. Please don't negotiate with these kids unless there are choices. So again, right or left, that kind of thing. And if you praise them for cooperating, a lot of times these kids will be extremely cooperative with you. Gosh, you did such a good job holding still. I'm going to need that for you to do that one more time for me. And those are the kinds of things that these kids will really relate to, and then they will continue on with the exam and helping you out with it. Next. And then there's the adolescent age group. You want to encourage questions from them and show them respect. And being honest and non-judgmental. These kids will get into more trouble sometimes than you can possibly believe that they've gotten into. The 16-year-old that is texting and driving and drinking at the same time, it's really hard for them to understand that they probably are not good to drive a car at that point. And they'll be very angry or frustrated when that actually happens, that they wreck the car because they were doing all of those things. You got to try and keep them from getting angry with you for whatever reason. A lot of these kids have a lot of anger anyway. And they remind me of cats. They can sleep for 12 hours a day and never move a muscle. And they can sneak off like no other. So they're kind of like a cat in that way. You also need to talk to teens about decision-making and kind of what they've done. You just never know what they're going to tell you. And they will tell you about anything if you just ask them and don't make any judgment calls on it. So we'll just, adolescents are just a breed of their own. Next. So with your initial assessment, if it's an injury, sometimes the assessment is really straightforward. If you have a head-on motor vehicle collision, you can kind of guess what the mechanism or the known cause is. The hard part is when you have to evaluate for less obvious injuries. Pediatric patients as a whole, 83% of the time will have bleeding that is not external or anything that you can see. So 17% of the time you can see it, the rest of the time you cannot. So you have to be extra suspicious of a motor vehicle crash or any kind of injury that includes G-forces, that they probably have internal bleeding before they show anything externally. So you have to really evaluate for those less obvious injuries, which will include like the chest or abdomen. 25% of the pediatric population that's involved in a motor vehicle crash will have some kind of pulmonary contusions. It's lesser in the adult population, and part of the reason for kids is that their rib cages are very cartilaginous until they actually develop, until they get the strong calcium bone growth into them. And so that's why so many of the G-forces are transferred into the internal pulmonary organs. And so they'll have the pulmonary contusions that you don't see as much in the adult population. The good news for them, for kids, is that they don't realize a cause and effect. So they don't realize a lot of times that when they breathe and it hurts, they don't hold their breath or do shallow breathing like the adult population does. They just continue breathing, which is why they get better faster. They just don't realize it. Next. If it is an illness that you're dealing with, you really need to ask some very specific questions. When did it begin? Is this something that's been going on for 12 hours or 12 days? What are the symptoms that are going along with it? Is the child seeing things or picking spiders out of the air, which gives me a good indication of an altered mental status? Or are they just, is their muscle tone limp and are they lethargic and not even hardly talking at all? How long have the symptoms lasted? Again, is it just a few days? Has it been weeks? Have they been sick for 3 days, but now all of a sudden they have an altered mental status to go along with it? And has the child also been seen recently? One of the things that I have found is that parents, a lot of times, if they don't get the answer that they want out of one person, then they'll move on to the next. And they've also had treatment that's been associated with that. And unless we ask, we don't know. So that's one of the things that I always make sure I ask is, has the child been seen recently? And if so, by whom? And what did they tell you? Next. So whether the child has either an injury or an illness, the pediatric assessment triangle is going to help identify the physiologic instability of that particular child. This becomes overall the most important thing that you can do because it tells you whether or not you can stay and play or whether you need some kind of an immediate intervention. And so this is the sixth sense that I was talking about earlier, and we'll go through this one item at a time. Next. With the pediatric assessment triangle, really what it is a rapid initial assessment of the child. And as you enter the room, it's the very first step that you take, and you start looking at the child from the doorway. It's only using visual and auditory clues. So it's what you see and what you hear. It's not anything that puts a hands-on with this particular child. But what it does do for you is develop a general first impression of this kid. Or how sick are they? Are they sick, sicker, or the sickest of children? Next. Now, the pediatric assessment triangle really has 3 components. The first one is the appearance of the child. And we'll talk about each one of these individually. Second is the work of breathing. Now, you'll notice we didn't say what's the respiratory rate. We're asking how hard is a child working in order to breathe. And then the last piece is circulation to the skin. What do they really look like? What color is their skin? Next. The PAT is based on listening and seeing, and it doesn't require any equipment whatsoever. And it's actually completed in just that first 30 to 60 seconds that you have eyes on that particular infant or child. Next. With appearance, it's that very first impression. It's when you're looking at the child for their mental status. It could be what their muscle tone is like or their body position. Are they limp and flaccid, or are they sitting up and playing with something? 2 totally different kinds of kids when you're looking at appearance. Next. And you can use the mnemonic tickles. This is really what we're looking for in that particular pediatric child. What's their muscle tone like? Are they, again, playing with something, or are they flaccid and floppy? Are they interactive? Are they looking around and interacting with their environment, or do they have that kind of deer in the headlight look where they just are kind of staring off into space? One of the big things is, are they consolable, especially if they're an infant or small child? Usually an infant or small child that has been fed and is dry is usually quiet and consolable. If a child's not consolable, there's something else going on with that particular kid. And then two, their look or gaze. Again, the deer in the headlight look. Are they staring off into space? And the other thing you can talk or think about too is their speech or their cry. If it's a really high-pitched cry in an infant, that's what we call kind of a neuro cry, meaning that they probably have something going on neurologically or in their head, something like meningitis. If they have garbled speech, is that the normal for that particular child? Does it sound the way they normally do, or is this something new for this particular kiddo? Next. Your appearance really reflects the adequacy of ventilation, oxygenation, brain perfusion, whether the body is in homeostasis or not, and their central nervous system function. The one I can think of, that there was a 12-year-old that was brought in and the dad was carrying her. And the first thing that you would notice about something like that is 12-year-olds don't usually get carried into a setting by their parents. They usually walk. And when you ask what's going on, the dad said, well, she's been picking spiders out of the air for the last 2 hours. And, okay, this kid has an altered mental status, what else is going on? And as you dig a little deeper and find out a little more about the history, this particular kid had been sick for 3 or 4 days, but in the last 2 hours, all of a sudden her mentation has changed and it's dramatically different. That's a kid that's sick. And just the appearance alone gives you that information. Next. The alert and interactive child is usually not critically ill. Now, there's some cases where that can be deceiving. The first is when they've ingested something. So we can have a kid that, and the one I'm thinking about in particular, happened to drink his grandma's digoxin. She had it in liquid form in the refrigerator. Kiddo got up, drank it during the day. Then after 2 hours, 3 hours later, every time the child got up, he passed out onto the floor. And once he got down on the floor, then he kind of woke up again. Well, his PAT didn't really show anything. He looked like he was just a normal kiddo, but because of the toxins that he had ingested, in this case, digoxin, it was causing him to be critically ill as a result. Trauma emergencies are the other thing. They can be very, very suspicious, and you don't always realize how sick the kiddo is. You can have a great example was an 8-month-old that we had coming in, involved in a motor vehicle crash, had to be extricated from the car, was about a 20-minute extrication, bitterly cold weather. Child cried all the way into the emergency room or the emergency department, where he coded immediately outside of the ER. The child had a tremendous bleed into his brain. But the problem was that, number one, you couldn't see it. Secondly, the kid was really cold. And thirdly, kids have a great coping mechanism in order to basically decrease their blood flow to just their head and lungs and to the vital organs. So they do that extremely well. They haven't had the Burger Kings and the Big Macs that everybody else has had as an adult. And so they do it very, very well. But they can fool you because that's a huge traumatic injury that really was not very well picked up on. The staff just didn't realize it. Next. So while the appearance reflects real illness or injury, it doesn't always show the cause of the illness or injury. That's something you have to dig a little deeper for in most instances. Next. So the second part of that pediatric assessment triangle is the work of breathing, and it's an accurate indicator of oxygenation and ventilation. And it does more for you than actually respiratory rate or sometimes chest sounds on auscultation. Next. So when we initially are taking our second step into the room and we've already seen the child's appearance and now we're looking at that work of breathing, we're also listening at the same time. Do I hear any abnormal airway sounds? Is the child positioned in a strange way? We talk a lot about the older kids being in the tripod position if they're having difficulty breathing. Retractions are sometimes out there. Sometimes you can see them even through the clothing, or sometimes the kids are bare chested, and so you can see, do they have tracheal tugging? Do they have substernal or suprasternal retractions? When the child breathes in, do you see every little rib that's in their rib cage? Are they showing signs of nasal flaring? And that's where the nostrils just flare out a little bit. And we'll talk a little more in depth about each one of these. Next. Abnormal airway sounds could include such things as snoring. Sometimes it's a kiddo with a muffled or hoarse speech. If they have stridor, which gives you an indication of an upper airway problem. Grunting is out there. Again, signs of a more severe respiratory illness. And sometimes you can hear audible wheezing. Those are all not normal. Normally, you don't hear the person next to you breathing. So each one of those gives you a different indication of what's going on with that particular kid. And you know it's not necessarily good. Next. With abnormal positioning, again, we talked a little bit of the tripod position. The other thing with kiddos is a lot of times you want them in a neutral sniffing position. And for those of you who may not be aware of that, that's really where the ear matches to the basically the clavicle or the shoulder blade. We want the kid's head to be in alignment. Now, the little ones are all head. They basically have this huge occiput. And so in order to get them into a neutral sniffing position, you really have to raise up their shoulders. And a lot of times padding with a towel roll or any other, an extra set of sheet, anything that you might have that will actually even out that head to the rest of the body. Because if that head is, you've all seen probably the little tykes that are all crunched down in their car seats, and you're wondering how they're even breathing because their neck is like in such a strange position. A lot of times it's rolled forward or sometimes it's rolled to the side. It's not unusual for kids to drop their pulse ox readings a little bit when they are sleeping because they do have a tendency to shut off their airways just a little bit, which is why that neutral sniffing position is nice because that opens up the airway. Either one of these things, though, can indicate severe respiratory distress. And so you want to really get the kids into a position where their work of breathing is the easiest for them. The older kids will do it naturally. Younger kids, you may have to assist with. Next. Retractions, we've talked a little bit about use of accessory muscles. And then head bobbing is the other thing. And that's where you probably done it yourself at different times when something's been boring. And what you find yourself is kind of nodding off to sleep. And so your head kind of drops. And then all of a sudden you yank it back up again. And that's what these kids do too. That head bobbing, actually, what they're trying to do is open up their airway in order to oxygenate themselves a little bit better. Now, if they have one set of retractions, just like little, short intercostal retractions, they're probably not as severely in respiratory distress as, say, the child that has a whole slew of different kinds of retractions. The more retractions that they have, along with either grunting noises, snoring noises, those are all indicators that the child is moving closer and closer to out of respiratory distress and into failure. Next. That nasal flaring that I talked a little bit about is a form of accessory muscle use. Again, it's that exaggerated opening of the nostrils and occurs really during labored inspiration. And it indicates that moderate to severe hypoxia. Again, they're trying to open up the nares in order to get more air in to alleviate the respiratory distress that they're in. Next. So with the work of breathing, you want to listen really carefully from a distance. You want to see if the child has any abnormal positioning, undress and observe them for those retractions, and then watch for that nasal flaring. Be sure and document anything else that's going on with that kiddo. Grunting, snoring, those are all signs of some kind of impending, not only respiratory distress, but it's getting more severe as it goes. Next. So the type of abnormal airway sound give an important clue to the location of the illness or injury in kiddos. And next. The larger the number and type of visual signs for increased work of breathing gives you the varying degrees of physiologic distress. And so we'll talk a little bit more about how you can tell when you start using all the components of the pediatric assessment triangle together, how it tells you how sick these children either are or are not. Next. Now, the other thing is, for those who are cyanotic, it's always a critical sign. It indicates that the intervention that you either have done or that you need to do some kind of an immediate intervention. I had a pulmonologist tell me one time that when kids become cyanotic, they're down about 50% in their bloodstream of oxygen. That's if you think about that, if they're blue around their lips or around, you notice around their nail beds or eyes, the circummoral cyanosis, again, that's around the lips. That's a bad indication that that kid is moving close to failure. If you add that to that they have an altered mental status, and these kids are in respiratory failure. And so it's always a critical sign. You're going to have to BVM these kids or give them not just supplemental oxygen, but probably going to have to bag for them. Next. The third component then of the pediatric assessment triangle is circulation to the skin. And really your goal is to determine the adequacy of cardiac output, core perfusion, or perfusion to those vital organs. Now, the kids will shut down their bodies in a variety of methods, but usually they'll start with the furthest lying areas first. So what you'll see is all of a sudden their nail beds and toes will get pale. They'll move because what they're doing is they're shunting their blood to the core in order to take care of the vital organs that are in the core itself. Kidneys can handle about 2 hours without great circulation to them. Skin can handle about 8. But you and I both know that when you're talking about heart and brain, you're talking less than 10 minutes without good circulation. So, the circulation to the skin is going to be an indicator as well of how sick is this particular child. Next. So some of the important signs of core perfusion is if that cardiac output is low for whatever reason, the body shuts down circulation to those non-essential areas. And if you think about highways and byways, right now we have tons of construction going on where I live in the metro area. And if we take a freeway that's 4 lanes deep and all of a sudden we move it down to 1 lane, you know how quickly things change. And kids are very good about moving their blood down to basically that 1 lane in order to perfuse what they need to perfuse the most. And that's their head, lungs, heart. Next. So with that initial impression, I need to know if this kiddo is pink, which means that their circulation is okay. Are they pale? Are they mottled? Or mottling means that they've got that kind of spider webby look to them, or they are cyanotic. Next. So what we're going to do is we're going to take those 3 components of the pediatric assessment triangle, and we're going to ask a couple of questions. How severe is a child's illness or injury, and what's a physiologic abnormality? Now, when we're trying to decide severity, I'm going to go back to that pediatric assessment triangle. If they have nothing that falls out, so if their appearance, work of breathing, and circulation all looks normal, then what they're being, you're going to call them sick simply because the parents say they are. They're the experts, and something has gone on that has brought them or had them call for emergency medical services or brought them into the emergency department, depending on where you're working at. If there is one thing that falls out of the pediatric assessment triangle, so for example, let's say their work of breathing is increased and they have retractions, but their skin is still pink and they're still interactive with their environments and their appearance is okay, then they're sicker. These kids are probably ones that you have a little bit of time to interact and intervene before they become critical. If, on the other hand, they have 2 or more things that fall out of this pediatric assessment triangle, they have an altered mental status and increased work of breathing, or they have an altered mental status and their skin is cyanotic. These are the sickest kids, and they need absolute, quick, immediate intervention in order to reverse them. They are in deep trouble at this point. So that's how that pediatric assessment triangle can help you. Again, Nothing falls out, kids are sick because the parents say so. One item falls out, they're sicker. And if two or more fall out, then they're the sickest of the children that we take care of. And that can help with that physiologic abnormality. If I hear stridor and they have an altered mental status, I'm thinking upper airway disease. Altered mental status means they're probably hypoxic, and we probably need to do something immediately with either oxygenation and or ventilation. For the child that might be a diabetic with a high blood sugar, again, maybe they have an altered mental status and their skin is pale, but their work of breathing, even though it may be fast, when you put it out, when you auscultate them, their lungs are clear. It's still a child that's extremely ill and needs immediate intervention, even though the respiratory rate is maybe fast, but their lungs are clear. It's, obviously they're trying to blow off and increase their pH is what I'm trying to say. Next. So really you need to figure out what your most appropriate action is going to be, how fast to intervene, and what type of treatment to give. And again, that's going to be based on what is the chief complaint of the child or the parent, and then what are the physiological things that you have seen just from the doorway, and then whatever else you might have into your initial impression. Next. So you really need to determine if your kids are emergent or non-urgent. If they're emergent, you need to immediately provide initial interventions. It may be bag valve mask. It may be that they are dehydrated and you need to get a line going and provide them with fluids. If it's non-urgent, the kid with the stub toe, as we call it, or perhaps they are, I don't know, maybe they've got a little bit of respiratory distress. You might want to build a rapport as you get ready for a neb treatment that maybe is going to help them, and then begin your full initial assessment. Next. So the initial assessment really is going to be the same as the adult population. We're going to talk about AVPU. So are they alert, respond only to verbal, painful, or are they unresponsive? What's their airway, breathing, and circulation like? And we've already talked a little bit about cap refill. Next. And you can use the CUPS assessment as well. Are they critical, unstable, potentially unstable, or are they stable? Next. So a kid that's critical would be anything that's abnormal, or not abnormal, absent on airway, breathing, or circulation, or if they're unresponsive, becomes the critical child. Next. If they're unstable, probably their airway, breathing, or circulation is compromised in one way, shape, or form, and they may be semi-responsive or lethargic. These kids still need immediate intervention in order to turn them around. Next. The kids that are potentially unstable, these are the ones that are kind of interesting because sometimes they just have an isolated altered mental status and you don't know really what's going on, like the kid with the toxicologic emergency or that they've ingested something. A normal exam, but they have a high risk of having some kind of internal bleeding or some kind of internal injury because of their mechanism of injury. Children with special healthcare needs are really an interesting population in and of themselves. And the reason for that is I always think about kids with special healthcare needs as always being on a balance beam, especially since we've just been through the Olympics. They're always ready to fall off. Their main, in order for them to a lot of times maintain homeostasis, it takes a lot of effort and they don't have much reserve for them. So I always watch those kids in particular. The thing about them is you need to ask the parents what their normal is. They'll bring in a kid that may be totally obtunded and I'll say, so what's going on with this kid? And they're like, well, he's got more secretions that he normally has. Or it might be that the child can actually walk and talk, but he's curled up in a fetal position. That's a kid that's probably a lot sicker than what you would think that he should be. And then the kids with chronic illnesses, a lot of times they'll be able to tell you where they're at. The kid with cystic fibrosis, acute anemia, there's all kinds of different things that add comorbidities to whatever their acute status is at this point. And so they're always potentially unstable as well. And we run into a lot of them. You've got the kids with maybe sickle cell anemia or that have some kind of oncology issue. Those again will make a big difference. Next. And then the kids that are stable, isolated illnesses or injuries, minor illnesses or injuries. These are things that you can kind of stay and play with, and do a little more of your initial assessment before you have to really intervene in anything. Next. And then you need to decide what the kind of transport you're going to have. Do these kids need to go to an emergency room? Do you need to take them by ground, air? Is there a transport team that specializes in pediatrics? Is there something like that that's available? Sometimes that might be your best option in order to get the child to the right place in the right amount of time. And next. Any questions?
I wanted to go back to your one comment that you made about checking the circulatory status of a pediatric patient. I know when you're doing the cap refill, I think a lot of people forget about the idea that that extremity that you use has to be elevated above the heart in order for that to be effective in there. And I think it's a very, very valid point, you know, that we need to continue to bring forward in there. And I appreciate you doing that again this evening.
You know, that's one of the things that we see probably the most often as a potential for error, that you hear, well, the cap refill is normal, but then when you go to lift it above the heart, all of a sudden it's not quite as normal as what we thought it was. And so that cap refill is going to be a big one. The other thing about kiddos that we need to remember is, especially taking care of them versus an adult population, you know, with adults, a lot of times we go to the blood pressure first. And with kiddos, we go to the blood pressure last. They have their cardiac output, if you recall back, is stroke volume times heart rate. Kids cannot really change their stroke volume for a number of years. They've got these nice, strong, tiny hearts. And so the only thing that they can do to improve their circulation or to improve their cardiac output is to increase their heart rate. By the time their blood pressure drops, they can have as much as a 50% loss of blood volume, or either from an internal injury or from just being dehydrated before they ever drop their blood pressure. So really the key indicators for kiddos is looking at that heart rate. And if it's 10 to 20 beats above normal, that's about a 10% volume loss for them. So, you know, knowing what the normal values are is not as important as just having a resource that you can go to that says, oh, a 2-year-old should be having a heart rate of this. And all of a sudden I'm finding this kid's got a heart rate of 180. That's probably, and they're not crying. That means that that kid's is dry. They've got something.
Flower toss.
Okay, I apologize. We got them muted now. Well, and again, I think you bring up another good point to remember too, is that the pediatric patients and everything, they compensate so well, and they can hold that line for a lot longer than adult. But when they decompensate, it's almost a straight drop off, as opposed to a gradual plateau that we usually see in the adults.
Dr. Meeks, I got another question for you. We're going to hear terms like COVID babies and things like that for a long time. The world kind of changed when that virus passed through us. But in general, kids with respiratory issues a lot of times it seem just like they're just not quite right. What do you think about discussing the importance of effort to breathe and noticing things like sternal retractions and that kind of stuff on little ones when they're sick?
Yeah, that's a super point, Will. The thing about kiddos and their respiratory efforts and that, along with what Steve had to say, is they will respiratory distress is huge in children just because their airways are so small. So a little bit of edema or a little bit of secretions in a very small airway leads to a lot of compromise. The other thing about kids is that, especially in the infant stage, 0 to 6 months, they are obligatory nose breathers. So what that means is they can only breathe through their noses. They don't know to breathe through their mouths like an adult does. So when you and I get a cold and our noses are all stuffed up, we just automatically breathe through our mouths.
Yeah,
Those
they'll choke
kids,
through it. Yeah.
yeah, those kids that are 6 months old and under can't do that because they don't know to do that.
Yep.
And so keeping their airways open is really important. And a lot of times when especially if they've gotten something like COVID or RSV, they have this huge amount of nasal secretions, and just keeping them sucked out before they feed is real important.
Thank you.
Yeah.
And Reylon, maybe a couple words on oxygenation of the pediatric patient and everything too, because a lot of times they won't tolerate the mask and everything, but they do well with blow-by oxygen, where you can use, a stuffed toy or something like that.
Yeah, the utilizing the oxygen mask with an infant or small child, sometimes they'll fight you every step of the way. Now, what I will say about that, if they need oxygen, they really need oxygen. And I would just as soon have them fighting me and me holding it onto their little noses. And the reason for that is I'm the adult and I can do that. And the harder they cry, the more oxygen they're going to get in. So frankly, that's a really good thing to have happen. I'm glad that they cry. In fact, I like the kids that cry because that tells me that they're probably mentally better off than the children who don't do anything.
That's a good
They
point.
do have
This is,
masks out there that look like little dinosaurs, and some of the kids tolerate those a little bit better because you tell them to roar into their mask and roar like the dinosaur. So they'll take this big, deep breath in order to roar like a dinosaur, which is exactly what we want because guess what? Then they breathe in all the medication that you're giving them, and that's what we want to have.
that's a good point. If a kid isn't upset because you're doing an exam, there's probably something wrong with the kid.
That kid is terrifying to me.
Yeah.
If they don't scream and cry and yell when you start an IV, that kid is incredibly sick, and they terrify me the most.
Yep.
I want them to be mad at me.
A question here, and they wanted to address the practice of transporting the child on mom's lap.
Oh boy, that's a can of worms. So my answer to that is no, 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 and no. There are now available multiple sized transport mechanisms, and I don't advocate for any one or another, but that will actually secure the child appropriately to the cot or to the gurney, whatever you want to call it. These have actually been crash tested in ambulances so that we know that they're appropriate for the crash test of the child. The kid is not going to die if they're not in the mother's arms for a short period of time. So, it's the only thing I can say is that's the most appropriate way to transport a child. And I know that there's all kinds of things that go on. If you, especially to OBGYN is another one, but if you have a mother who's delivered, the appropriate thing is an ambulance for the infant and an ambulance for the mother. Again, it has to do with safety purposes, and you've got two patients, not just one now. So you don't normally transport two patients in the same ambulance. So that's what I would say on that. I know there's extenuating circumstances and all of that, but the safest thing for the child is to put them into some kind of a pediatric transport carrier that's been approved. That's a great question.
Dr. Meeks, I want to thank you again for joining us tonight. Your commitment to the McSwain Trauma Education Project is greatly appreciated, both for our conferences and now joining us here on the third Thursday.
Well, it's always a pleasure to work with you guys. I can't say enough about that. The importance of education all the way around. So Mary, thank you and your foundation for everything that you do. And we're really looking forward to having better pediatric care throughout the world.